Hello, I'm Dr. Simon Fry, a consultant in clinical neurophysiology. Welcome back to the channel, and in this video I am going to be talking about the third musketeer in this particular series on primary generalized epilepsies, and that will be juvenile myoclonic epilepsy. If you haven't already done so, please do support the channel by hitting that subscribe button down below. Your support is greatly appreciated. So the first thing to say is that juvenile myoclonic epilepsy, or JME for short, is actually quite a tricky diagnosis to make. Yes, it's quite a common epilepsy, so it makes up about 10% of all of those who are diagnosed with an epilepsy. And yes, in terms of its prevalence, the amount of it in the community, it's about 2 in 10,000. So for the UK population of 60 to 70 million, we're talking in the region of 12 to 14,000 people who will be affected with this. But it actually has a very broad age range of presentation. So it can actually start at the age of 6 and up to the age of 22. The majority will actually be presenting though in the teenage years, and half of them will be at about 13 to 16 years of age. Now, up until the point of having this as a diagnosis, development will usually be normal, and often there will be a family history of an epilepsy in about half of people. Sometimes there'll be a history of febrile seizures, and if you want to know more about febrile seizures, you can click on the iCard above for a specific video about that. And it was said in the past that there was a female preponderance to this, so the more girls than boys are affected, but more and more studies have shown over time that actually male-female ratio is about the same. In fact, what it might be is that sometimes the girls can present younger than the boys, and because of that it might seem that girls are more affected by this. So that you can see there's a bit of a discrepancy between how it is reported demographically, but really they're about the same. In terms of how it expresses itself, so the hallmark of this is the myoclonic jerk and myoclonic seizures. Now, these jerks tend to occur in the mornings, and half of them will present at the ages of about 13 to 16. Nearly everyone will have a generalized tonic-clonic seizure associated with this, roughly about 90%, but usually this will occur some years after that. Just to add into the mix of all of this, there can also be absence seizures as well, and they happen in about a third of people affected by this. And for men, interestingly, it might be more asymptomatic than for the ladies, and in fact can appear several years before the myoclonic components appear. So people can start having absences, and then at a later age start having myoclonic jerks, and then at a slightly later age start having generalized tonic-clonic seizures. So if on average the absences when they occur happen at the age of 11, the myoclonic jerks start at around about the age of 13 or so, and then the generalized tonic-clonic seizures start happening around about the age of 17, you can begin to appreciate that this is actually quite a complex entity with different parts of it potentially presenting at different ages, and because of that it actually makes it really tricky in terms of making the diagnosis. Now, the absence episodes, in contrast to both the childhood absence epilepsy and the juvenile absence epilepsies, tend to be very, very brief, almost momentarily, and actually quite infrequent, can happen less than once a day, and actually impair consciousness quite little compared to the other entities. These jerks and the seizures may all be provoked by sleep deprivation, alcohol consumption, and also menstruation. And so those things need to be considered in making diagnosis, but also in preventing these from occurring. And very interestingly, and the numbers vary in the literature, but roughly about 15% will have something called reflex induction. And that means that people can actually induce these seizures by doing certain things. Now, that might be doing certain movements. It might be to do with certain cognitive tasks. So sometimes certain types of calculation can do it. Sometimes eyelid closure can do this as well. And sometimes even jaw movements can do this. So reading, people sort of talk when they read, that can also trigger this off too. So it's really quite a fascinating entity in terms of what triggers it off. And because of the complexity of the presentation, it can actually take quite a long time to get this diagnosis. And one of the key points to this is that the myoclonic jerks, which is the hallmark defining aspect of JME, all in the name, is that the myoclonic jerks may be so subtle that they may not be appreciable by the patient or by their family or friends around them or by medical staff making the assessments. And in fact, some people may even have the jerks and just think they've always grown up with them and they don't think it's anything different to what anyone else might have. So it can take a long time for this to be diagnosed. There's another difference as well between who sees the patient. Are they being seen in a specialised centre, in which case it might take a couple of months for the diagnosis to be made from initial consultation, but it can still take a year or two when one looks at larger series. In non-specialised centres, it can actually take many years. So there's a difference in terms of who's seeing the patient, what experience they have with this in identifying the salient features. Part of the other aspect of the complexity of this is the clinical manifestations of it. So those who are having clear myoclonic jerks and myoclonic seizures actually have a shorter time period compared to those who are presenting with absence seizures. And that's no surprise really, because there are lots of other entities that can cause absence seizures. So it's a very difficult and challenging and complex area really of epileptology to actually get this diagnosis and to do so as quickly as possible. In terms of the myoclonic jerks, there are a couple of very important characteristics. So first of all, consciousness will be preserved, and a myoclonic jerk is a very abrupt, brief, involuntary movement, usually of the shoulders and the arms. And when we're talking about the shoulders and the arms, we're talking about an upwards contraction of the shoulders and also flexion of the elbow. So it's like that. These can occur singly, so one of these like that, or repetitively. There might be a few. When they do occur, they're usually arrhythmic. They are usually symmetrical, but can be unilateral, which can add to the confusion as well about getting the diagnosis. And in terms of the parts of the body that jerk, it's 90% of the time when it's happening, it will be the shoulders and the arms doing that movement. But about 50% of the time, it will be the legs making some jerking movements. About 25% of the time, it will be the trunk. And that can include the diaphragm, can cause some breathing dysregulation with that. And about 10-15% might be within the face itself. The amplitude, as it were, the size of the movement is also quite variable as well. And yes, it can be quite large and very obvious, but sometimes it can be very small amplitude, very subtle, and sometimes it can even just be that the patient's feeling an electric shock type of sensation inside of them. And so it may not even be manifestly obvious to those who are making the assessment. Now, there are lots of other conditions which can be confused with it. So the easiest one to be confused with it really is juvenile absence epilepsy, because even that entity can have myoclonic jerks with it. About 5% of people with JME may have actually been diagnosed with childhood absence epilepsy several years earlier. And as I said, this can actually start in terms of its presentation from the age of even 6. It can also be confused with epilepsy with myoclonic absences, and that's a different entity. Tends to occur in younger people, very frequent absences, tend to be learning disabilities in the mix, and arm abduction is part of this. So as people are having the jerks, the arms are rising up as well. There's also an entity called epilepsy with eyelid myoclonia, and as I've mentioned, people can induce with eyelid closure as this condition too. So there can be reasons for confusion with that. People may think there may be partial seizures. I've said that sometimes the jerks may be unilateral rather than bilateral. There's another entity called generalized tonic-clonic epilepsy on awakening, and that can also be an entity that gets confused with it. There's a whole bunch of myoclonias as well, which may be physiological, such as when people go to sleep, people can have some jerks, or maybe due to other illnesses. There's quite a long list of those. Sometimes it can even be mislabeled as stress, which is very unhelpful, and there's a whole list of other differentials too, and those are just some of them. So there's quite a broad mix of things which JME may be confused with. In terms of making the diagnosis, so it starts always with clinical evaluation, hopefully by an experienced physician or paediatrician with a broad experience of the different types of epilepsies. The clinical evaluation should really be normal. The EEG will come on to in a moment, and imaging, broadly speaking, is normal, but we'll possibly come back to that. In terms of the EEG, in terms of the background, there shouldn't be any focal slowing or focal discharges. Sometimes you can get these fragmented spikes or polyspikes. One may see interictal generalized spike waves or generalized polyspike waves, again a little bit on the faster side, so about 3.5 to 6 hertz. Sleep and sleep deprivation can enhance the discharges and also the fragmentation and the duration of the discharges. Hyperventilation may be a trigger, may enhance some of these discharges. And very interestingly, intermittent photic stimulation is quite a potent activator of the discharges. It's quite a variable literature in terms of what percentage of people who have this condition are affected by intermittent photic stimulation. So it may be somewhere between 30 and 60%, depending on the case series that you're looking at. But the most fascinating aspect of this is that in terms of day-to-day life, only about 10% of people are actually photosensitive in terms of if they're watching television and seeing flickering lights and so on. So although it's quite a feature in the laboratory, in day-to-day activities, it's not such a feature. In terms of what happens when people actually have a seizure, then one will be expecting generalized spike waves at 3.5 to 6 hertz or so. Usually, though, there's a lot of obscurity whilst people are actually having the seizures of the signals by muscle artifact. But when people are having general tonic-clonic seizures, the general pattern with these things is that one gets fast spiky activity, 14 to 16 hertz or so, and that happens in the tonic phase. And then as they go into the clonic phase, then you get the spike slows and then irregular slowing thereafter in the post-ictal phase. In terms of treatments, so the first line treatment is really sodium valproate. Its efficacy is roughly about 80 to 85%, depending on the case series that you're looking at, and is a very good option. However, for young childbearing age ladies, and this is something that affects teenagers, young adults, and is something that tends to be an ongoing issue. One has to think very carefully about that because of potential effects on pregnancies. So there are alternatives as well. For example, lamotrigine, that tends to be quite a popular choice. There are flip sides to everything, and the higher doses of it actually may exacerbate some of the myoclonic elements or generalized tonic-clonic seizures. There are other agents such as topiramate, levetiracetam, and clobazam, which may all be useful. And sometimes one might need to go for combination therapy. But there are some anti-epileptics one has to avoid: carbamazepine, phenytoin, gabapentin, vigabatrin, and tiagabine. So those can all exacerbate the myoclonic side of it. So there are lots of different alternative choices that can be had to the sodium valproate, and there are conversations to be had basically as to what might be the best type of anti-epileptic for an individual patient, and of course some have some side effects which people may not wish to have, and everyone's affected slightly differently by the medications that we all end up taking. So those are the usual standard treatments. In terms of remission, so unlike childhood absence epilepsy and also, again, juvenile absence epilepsy, but to a slightly different extent, remission is generally accepted to be unlikely to be achieved off anti-epileptics. and even those who are taking anti-epileptic medications long term, there may be some relapses too. So it's important to really appreciate the fact that whatever anti-epileptic medication one is started on, that is likely to be continued for a long time, and anti-epileptic medication reduction and cessation may not be feasible. There are also, apart from that, apart from the epilepsy side of it, it's important to consider what we call the psychiatric aspects of those who have JME. It's quite common for people to have issues with anxiety, with mood and personality type issues as well, and those need to be addressed as part of holistic, all-encompassing treatment. Of course, there are also some cognitive aspects as well, on attention, verbal fluency, cognitive flexibility, and they have to be factored in for schooling and further education if that's something that people want to pursue and be supported through. So going now into the genes, this is where it gets really complicated, both in terms of individual genes, polygenes, so that's multiple genes perhaps malfunctioning, epigenetic factors, which means things which trigger various genes to be expressed at various points, and then environmental factors. And the reality is there are lots of genes and channels that have been studied which might explain parts of this, but it's very difficult to actually say it's one or two genes that are responsible for JME. So we know that there are various potassium channels which are expressed in the teenage years, which if they are defective may actually impair the neuron's ability to hyperpolarize and therefore dampen down signals, so they might become excitable that way. There are various chloride channels which can reduce the sensitivity to GABA, which is the neurotransmitter which dampens down the neurotransmission within the brain. There are various calcium currents and channels which may either be enhanced and to allow a hyperexcitable state, or may actually impair development of the teenage brain as it's going forward, and various GABA channel malformations and microdeletions, and there's a whole load more. So there's an evolving literature. It's certainly a watch this space. It's not so clean cut as perhaps some of the single genes that have been identified for childhood absence epilepsy. So it's a very complicated area. It's a very complicated expression, as I've already said. Absences, jerks, general tonic-clonic seizures, all variably expressed in terms of the patients. But again, the genes, the channels potentially involved, again, very, very complex. Now, I briefly touched upon before that imaging is normal at diagnosis. This is quite complicated. It's an evolving field, and depending on the quality of the imaging, there can be some subtle irregularities that are picked up, and that's again another area of investigation. I hope that you found this video helpful, in particular in terms of elucidating why it's such a challenging diagnosis to make, both in terms of how it expresses itself, also in terms of the genes involved, and also really in terms of how people respond to treatment as well. So if you have found this video useful, please feel free to hit the like button down below. Also, you're very welcome to comment. Again, as always, I can't answer personal individual questions, but if it's about the condition in general, I will try my best, and I look forward to seeing you in the next video. All the very best.